When a patient presents for implant treatments, and we refer the patient to have the implants placed, as a restorative dentist, your heart almost drops when we have implants not in the most ideal locations. What do you do? How do you restore patients like this where the long axis is not exactly most appropriate? Or patients like this where two implants are so close? What's the interdental tissue going to help in presenting in the definitive restoration? Or the long axis of a patient like this? How do we manage the restorative outcomes? Or a patient presenting with pain comes in, implants replaced. What are some of the issues? Is that implant really where we think it's going to be? Is it where we thought we placed it? Or maybe it's your best friend that comes in, had implants placed in at a younger age, and said, I want to change my crowns, get a new smile. What type of issues do we have when the implants are not in the most ideal locations as what we expected, where the long axis may be, or where the positions creates issues and problems with the restorative prosthesis? Well, is it where the bone is? That's where the implants are placed. But is there something else that we can do today with software that we can have more of a team approach and understanding where the most ideal position of the implant will be based upon the restorative component, but also for the surgical component and where the bone is and where we need that implant to be? But what about the comparison? We've always seen before this traditional surgical template. But how about that CAD/CAM template? Well, interesting is that Cement looked exactly at that. He wanted to make a comparison between the traditional surgical template and a CAD/CAM surgical template. He took 5 surgeons and looked at 5 epoxy edentulous mandibles. And they planned implants using a radiographic template and taking that radiographic template and converting it into a surgical template based upon the CT scans. And in comparison, made 5 CAD/CAM templates from the surgical planning and then placed in the implants and made a comparison between the planned implants and the surgically placed implants. In that comparison, they looked at the position where it was planned and the actual placement of the planned implant. They looked at 3 positions. And in fact, most of the articles and most of the research will look at these 3 positions, where the point of, in comparison of the head of the implant, or the center point, the apex of the implant, and the divergence angle between the long axis of the 2 implants placed. What they found is that in the traditional surgical templates, compared to the CAD/CAM templates, the head of the implant in a traditional template was about 1.5 millimeters in comparison to the planned implant. And in a CAD/CAM template, 0.9 millimeters at the head of the implant, compared to the apex, 2.1 millimeters, with a CAD/CAM template, 1 millimeter, and the angle divergence of 8 degrees versus 4.5 degrees. Well, they concluded, based upon the clinical significance of this information, that CAD/CAM surgical templates will improve implant placement. Well, there's basically 2 techniques with CT-guided surgeries. One would be a rapid prototyping of the templates, or a CAD/CAM surgical template, and the other is navigational systems, some type of optical tracking to place in the implants in real time. Interesting study, Rupin wanted to compare, well, the 2 different techniques. How accurate are those 2 techniques? Is there a difference? Well, they compared the 2 different techniques of the CAD/CAM surgical templates and the optical technique, placing in 120 implants into 20 edentulous mandibles, cadaver mandibles. And the aim was to see the accuracy of these two templates. Conclusion? No true difference. No significant differences between the two techniques. So what is the problem is practicality. With an optical system, all this armamentarium, is it really equivalent to or the need and desire of the optical system, the accuracy, in comparison to a CAD-CAM surgical template? But how accurate are those CAD-CAM surgical templates? Well, when we looked at this, Weidman looked at, in a review, the differences of how we planned versus how it was being placed onto the patients. He called this the image to physical transformation. It was the precise transfer of the virtual planning to the surgical site. It was necessary that we have an accuracy in registration, but also mapping the image data in comparison to the physical space of the patient. They were done this in two different ways. One was surface mapping, that is, a cast of the patient was made, and by anatomical landmarks looked at positioning the two, and the other was fiducial related. That means some type of fiducial, some type of marker being placed onto the patient or fixed location, or using it with some type of surgical template or radiographic template. With the CAD-CAM surgical templates, what they found and concluded was that errors were the result of an unstable fixation of the template. And so therefore we want to keep it a most rigid fixation to the patient. We want to have a precise mechanical fit of the template. And also, if the templates are made on a cast, we want to have very accurate impressions and accurate cast. But how accurate are these? Are there any clinical studies? Well, Di Giacomo did a study looking at 4 patients. They placed 21 implants using radiographic templates, CT scan, Implant, and Surgiguides. 3 templates were fabricated for different size of the twist drills for the osteotomy site, and they were bone and tooth-borne templates. The templates were removed, and then the implants placed, and then the second scan was made. What they found? At the head of the implant was 2.45 millimeters with a range of 0.2 to 4.5 millimeters. At the apex, 2.99 millimeters with a range of 0.8 to 7.1 millimeters. And an angular comparison, 7.25 degrees with a range of 3.6 degrees to 12.2 degrees. Well, Van Steenberg looked at it in a little different way, and he developed a technique along with Mats Andersson where the template was truly fixated to the patient. The osteotomy was completed through the surgical template, and the implants were also placed through the template. In a recent study by Van Asch and Van Steenberg, looked at evaluating this for partially edentulous patients. They placed it on cadaver jaws, took pre and post CTs after the surgical planning using Nobel Guide. CAD-CAM guided surgical templates were fabricated, and 10 to 15 millimeter long implants were placed. What do they find? The degree of divergence, 2 degrees, with a range of 0.7 to 4 degrees. At the hex, or the head of the implant, 1.1 millimeters with a range between 0.3 and 2.3 millimeters, and at the apex, 2 millimeters with a range of 0.7 to 2.4 millimeters. Their conclusions, they also looked at cone beam CTs and seeing if it was appropriate and finding that it was, having a maximum deviation, angular deviation of 4 degrees, and a linear deviation at the apex of 2.4 millimeters. But there aren't many studies in regards to clinical studies in the accuracy. So when we look at this, what are some of the advantages based on guided surgeries? Well, I feel that there's a precision of anatomical landmarks. That is, we have a better understanding of the anatomy, a safety for implant placement. We can avoid crucial anatomical landmarks, understanding the quality and the quantity of bone, and understanding how much bone lies around the implant when the implant is placed. And maybe, if we have a better understanding of the anatomy, we can place implants in without grafts. But the disadvantages are many. As we look at the advantages, the precision of implant placement, we have the accuracy needed due to anatomical restrictions, and a very precise placement due to restorative limitations. And we have precision for restorative procedures that would be for multiple implants, aesthetics, and then also predictability. Predictability, especially when multiple implants are being placed, for the accuracy based upon the restorative position. There are also disadvantages, though. Disadvantages to guided surgeries because of longer initial treatment times. Those longer treatment times are due to multiple appointments because of radiographic template fabrication or other preoperative procedures before we actually fabricate the CAD/CAM template. More radiation is a concern compared to two-dimensional studies, but with current cone beam CTs, is that really a problem? We have bulky instrumentation, especially with optical tracking systems, and difficulty in placement of the posterior segment, especially with longer instrumentation. And many clinicians are concerned about cooling. Cooling of the instrumentation during the osteotomy preparation, cooling it through the surgical template, and also cost. Initial cost setup based upon the cost of the program, and also for CAD/CAM templates. Who pays for it, and how is it completed? Well, when we looked at the studies, what is most publicized the most has been this Nobel Guide and the surgical templates. And in fact, long-term studies have been followed up with 30 consecutive patients by Van Steenberg and Sana, looking at 30 consecutive patients, placing in 212 implants with up to 5 years follow-up. They found 9 implant loss, 8 with smokers, having a 4% implant loss, 95% absolute survival rate, but 98.9 survival rate for non-smokers. Some other recent studies regarding guided treatments has been presented by Young and Moy, where they looked at 13 patients and 14 arches, 7 in the maxilla, 4 in the mandible, 2 partial maxillary treatments, and 1 partial mandible treatment. In their paper, they were treated all by 1 prosthodontist. It just so happens that I am that 1 prosthodontist following the protocol that was set up by Daniel Van Steenberg and Mats Andersson and the placement of these surgical templates. What they found and concluded after placing in 78 implants that was reported, an average follow-up of 26.6 months, they had 8 implant losses. 1 was at implant placement. That 1 that was lost at implant placement was because the implant was not fully seated when trying in the definitive prosthesis. That 1 implant was not placed all the way to the surgical template, and therefore had to be trephined out and therefore lost. There were those 7 late failures of our patients, 5 in the maxillary arch, 1 in the mandibular arch, and 1 mandibular partial treatment. Therefore having a 9% implant failure rate and a 91% survival rate. In my practice, when we looked at all the completely edentulous patients, including those in the initial study, I've treated 18 patients, 21 arches, 121 implants were placed from March of 2003, and the most recently treated patient was in October of 2008. But we followed a protocol such as this patient that was presented with a failing dentition. The patient had periodontal disease and decay, and the patient with the remaining dentition decided to have the remaining teeth extracted and complete dentures were placed. Following the protocol that was initially set up by placing fiducial markers in the denture, the patient was scanned and planned for a guided surgery. Once the plan was completed, surgical templates were created by the CAD/CAM or the stereolithography process, and the surgical template was used to fabricate a soft tissue cast, so that from that soft tissue cast we can mount it on the articulator based upon our initial setup on the articulator with an interocclusal record, and a provisional prosthesis was fabricated instead of a definitive prosthesis. Currently, all of our patients, instead of the definitive prosthesis being delivered, a provisional prosthesis is fabricated, but fixed and prefabricated onto the cast, all in one piece. And the other change is making the prosthesis direct to the implant without using any of the guided abutments or the adjustable abutments. The main controversy of the adjustable abutments, or the purpose of the adjustable abutments, was to allow for a change in the z-axis to compensate for passivity of fit. But my suggestion, or my conclusion, is that passivity of fit does not necessarily take place with immediate loading of implants, as well in comparison to osseointegrated implants. So therefore, if the system is as accurate as we think it is, and if the implants are placed to the positions that we feel that it's being placed, if the implants are off by the 1.1 millimeters or the small degree, maybe the implant will move slightly as we torque the prosthesis to place. But the restoration is rigid and holding the position of the implants as it goes through the healing process. Once completed, the surgical template, we will fabricate an interocclusal index for the surgical procedure as the original protocol. Once we receive and are ready for the surgery, the surgical template is placed, ensuring the proper fit of the template and also the surgical index, so the patient can occlude and the stabilization pins are placed, fixating the surgical template to the patient's mandible in this situation. The protocol of going through the osteotomy preparation of the 2 millimeter twist, the 3 millimeter twist, and then implant placement, we place both implants in at the same time to passively hold the surgical template in the position, not torquing the template, and the remaining implants placed as to the protocol. Once all the implants are placed, the surgical template is removed and the prosthesis is inserted to place, with the prosthesis checked and the initial occlusion evaluated, with our radiograph confirming the seat of all of the implant components. This is the patient 2 days post-op, 1 week post-op, and a follow-up of 3 months. The patient then was treated in the maxilla, and the same procedure was completed with our 1 week post-op in the maxilla. After healing and integration of the maxillary implants, the definitive prosthesis was completed by fabricating a metal and resin fixed complete denture, taking the patient to the completion of treatment. With this new protocol, what we found as we followed up with these patients, we're looking at a survival rate of the prosthesis of 96%, in the maxilla 94%, in the mandible 93%, and a total survival rate starting from 2003 all the way to 2008 of 94%. Well, we've also been doing other treatments and follow-up of the partially edentulous patients. In my practice, we've been treating 23 patients, placing in 76 implants through the guided treatment, of which 45 implants were loaded from the time period of March 2006 through May 2007. We follow the protocol such as this as patient presents for 2 implants in the mandibular right molar region. A diagnostic wax-up is fabricated and a radiographic template fabricated with an interocclusal record. The CT scans were completed and evaluated in our studies, looking at tooth positions of the adjacent teeth, mapping out the mandibular nerve, mantle foramen, and begin our planning of the implant positions in the second molar region and then also in the first molar region. After fabrication of the surgical template, we will alter the cast so that we can fabricate a soft tissue cast of the position of those 2 implants by retrofitting it into the original cast that we prepared. With the positions of these 2 implants, we're now able to consider placing any type of abutment or fabricate any type of provisional restoration if we choose to load the implants. In our study, in our protocol, we chose to load these implants, placing in 2 snappy abutments, fabricating a provisional restoration that was splinted together with the acrylic resin. And during the surgical procedure, the surgical template is inserted to place, patient seated into the surgical index to make sure that we have the proper placement of the surgical template, and an anchor pin is used to help hold the surgical template. Once completed, the surgery can begin with the start drill, 2mm twist, 3mm twist, and beginning with implant placement. As the implant is placed and the procedure completed, the abutments are inserted to place and the provisional restoration cemented in, keeping it out of occlusion so that they are truly provisionalized, immediate provisionalization, but not truly immediately loaded. As the patient and implants heal 3 months post-op, we can remove the provisional restoration, and now it becomes a restorative procedure by placing on the impression copings, making an impression, and then re-cementing the exact same provisional restoration. And in the laboratory, fabricated 2 individual all-ceramic restorations, all Procera crowns, and cemented them to place. Taking the patient from before, at implant placement, and at cementation, and then taking the patient in that pool. What did we find? Well, as we treated these patients, we're finding survival rates of the 121 implants, a 97% survival rate in the maxilla, having a 94% survival rate in the mandible. Anterior, we've had a 100% survival rate. In the posterior, 94.8%. We've lost a total of 3 implants, all in the mandible. And what's interesting is that 2 were not loaded and 1 was loaded, having a total survival rate of 96%. So when we look at this, what suggestions do I have for these CAD/CAM templates? Well, when we're planning, we need to look at some of the studies and the accuracy studies. As Van Asch and Van Steenberg have suggested, plan for the air and the maximum amount of air, and in this system, plan for at the apex a 2.4 millimeters of safety. We also need to make sure that the template is properly seated. In some of the surgical guides from Implant do not come with verification windows. My suggestion is to cut the template in certain areas so that you know that you have a precise seat onto the patient. Because remember that we need to have the image to physical transformation of the two. How do we transfer that position through the template onto the patient, the accurately positioned template? Which also means that we need to make sure the surgical template properly fits. Always try on the template. I do it first on the cast, and then making time to seat it onto the patient, making sure through the verification windows that surgical template is properly seated. And if you desire to have flaps laid, you can alter the surgical templates, cut a flap around the template, and seat the implants if necessary. Always have a rigid fixation. Make sure that there's enough teeth to rigidly hold the position of the implant, the surgical template, onto the patient, or using some type of fixation. And make sure that you have accurate casts to fabricate the radiographic template on or to fabricate the surgical template on. Accurate cast and impressions. So, guided versus conventional templates. What will we choose? As I've shown, there are many disadvantages. The list is quite long. But truly, I feel that the advantages outweigh the disadvantages in the comparison between the two. And that guided surgeries truly is the new wave of the future, how we will be placing in implants in the future of implant dentistry. Thank you very much.